The topic that we discussed today, insomnia, anxiety, the major we discuss here is the treatment part. So insomnia and anxiety do two things. Okay. Insomnia and anxiety may be attributed to a variety of underlying medical or psychiatric disorder, and symptoms may be exacerbated by hospitalizations too. Causes of insomnia include environmental disruption, mood, anxiety, substance abuse, common medications like beta blockers, steroids, bronchodilation. So the causes of insomnia can be what? Environmental disruption. Secondly, it can be mood and anxiety disorder. Third type, it can be substance abuse. Next, it can be medications. Medications like steroids, beta blockers, it can be bronchodilators. So these are a brief causes of insomnia. So here, three drugs, mainly three drugs. How these all causes insomnia? Because all these drugs can reduce the melatonin in the brain, especially beta blockers like propranolol. They are lipophilic beta blockers. They cause adrenergic antagonism, causing a reduction of melatonin in the brain. That's why they are causing insomnia. Next, anxiety may be seen in anxiety disorder, depression, substance abuse, hyperthyroidism, complex partial seizures. Anxiety, it can be seen in anxiety disorders. It can be seen in depression, in substance abuse, in hyperthyroidism. The thyroid hormone increases. It's a catabolic hormone. Heart rate increases. There's a chance of anxiety. Then complex partial seizures. These are brief causes. Next comes the diagnosis of uh, these insomnia and anxiety. See, the diagnosis of insomnia and anxiety is a clinical one, not a laboratory investigation or imaging test help, because uh, some are subjective mostly. So diagnosis, no lab test. So coming to the treatment of these problem. See, when you're treating this problem, you should understand that what are the major drugs, what are the causes, mechanism, and how we can treat it. Mechanism of insomnia. Insomnia is often considered a disorder of excessive activation of arousal system of brain, that is hyperarousal. The problem is hyperarousal. Physiologic, emotional, cognitive, depends. So what we have to do is we have to sedate the brain or depress the brain activity. So for that, primarily we use a drug called benzodiazepines. Pharmacology, most benzodiazepine undergo oxidation to active metabolite in the liver. So in liver, in the liver, the benzodiazepine move to the liver and form active metabolite. The lorazepam, oxazepam, temazepam undergo glucuronidation to inactive metabolites. So lorazepam, temazepam, then oxazepam. These undergo glucuronidation. These undergo a process called glucuronidation. Glucuronidation and form inactive metabolite. Okay, so that is the things. So let us discuss some of the main selected benzodiazepines. What are the selected benzodiazepine that we encounter usually in clinical setups? There is commonly used alprazolam as a anxiety buster or a stress buster, or a in anxiety disorder we use this alprazolam. The dosage is 0.75 to 4 milligram per day. So it can be given in divided doses, 3 doses. So it's used in anxiety disorder. The alprazolam is used in anxiety disorder as a per oral combination. Next drug is chlordioxyperoxide. We are familiar with this drug. In which condition? Yes, we use this drug in alcohol withdrawal problems. Alcohol withdrawal. So it can be used in anxiety problems as well as alcohol withdrawal disorder we use. The common medication dose is 15 to 1000, 50 to 100 milligram per day. We use this in divided doses. Next is the drug diazepam, the most frequently used drug in children for less rectal diazepam for seizures. We know that is used for similarly anxiety disorders, and it can be used for seizure disorder. It can be used as a pre-anesthetic medication. Okay, what is the dose? How many dose? That is a dose range of giving this diazepam is 6 to 40 milligram per 24 hour. For IV slow push, we give 2.5 to 20 milligram in slow IV push. Okay. Next class of drug is next type of a drug is loraz, lorazepam. Lorazepam used in anxiety disorder. It is given at the rate of 1 to 10 milligram per 24 hours or per day. Can be used per oral. Also, we use in IV like in seizure disorders or IM, that is 0.05 milligram per kg. Next comes the main drug that is called uh, flurazepam. 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 It's treatment in treatment for insomnia. That is, if you are not at all sleeping properly, you can use this drug, insomnia. Flurazepam. The dosage range is 15 to 30 milligram, which is given HS, that is at night. Okay. Next, another drug for insomnia is called temazepam. Temazepam. We just discussed temazepam, the glucuronidation and inactive metabolite in liver. The temazepam, the dosage is similar, 15 to 30 milligram at night, and it's similar for treatment in for insomnia. Okay. Next comes the drug similar for insomnia. We use another drug called triazolam. Like alprazolam, there is a drug called triazolam. It is also for treatment of insomnia, for treating insomnia. and the drug dosage is 0.125 to 0.25 at bedtime. Okay, this is a drug. So three drug we have studied for this sleep disorder. There is flurazepam, which is 15 to 30 milligram HS, temazepam 15 to 30 milligram HS, triamcinolone, that is 0.125 to 250 milligram HS. Next, we see the dosage. We just talked about the dosage. We just talked about the dosages. One more drug, let me say, is midazolam. In anesthesia, we use midazolam. It's used as an IV preparations in pre-anesthesia. Pre-anesthesia, like it is used as a 0.01 to 0.05 milligram per kg. Okay. Next comes the drug called. Next comes the side effects. What are the side effects that we encounter when you are using these drugs? Since these drugs, this benzodiazepine, what their action is. To discuss about the mechanism of action. Similarly, you see that these benzodiazepines, they go and bind to the receptors. There are receptors for this benzodiazepine, certain receptors. So this benzodiazepine goes and bind to the GABA receptors. GABA A receptors are the certain receptors. So what happened? It causes increased chloride ion conductance. When this benzodiazepine bind to the GABA receptors, it promotes the binding of GABA, increased chloride conduction. It results in hyperpolarization of neuronal membrane. Chloride conductance increases, hyperpolarization. These occurs. So the benzodiazepine sensitive GABA A receptors contain GABA and alpha A through alpha 5 subunits and mediate phasic inhibition triggered by peak concentration of synaptically released GABA. So it facilitates the action of it facilitates the binding of inhibitory neurotransmitter GABA at various receptors, causing these changes, chloride conductance and hyperpolarization, thus decreasing the excitability. So what all side effects we face? The side effects that we encounter. The side effects that we encounter are, first one is a psychomotor impairment. There are psychomotor impairment. Next comes, why psychomotor impairment? It's very common that these are drugs acting centrally, so it can occur. Next is that androgyny amnesia, means recent memory loss. Then, as usual, dizziness, fatigue, drowsy. That's because there are central depressants, depressive action, sedative actions. Okay, so this benzodiazepine toxicity is heightened by malnutrition, advanced age, hepatic disease, and concomitant use of alcohol and other CNS depressants and CYP3A4 inhibitors. The elderly may experience false, paradoxical agitation and delirium. You note one thing: we have discussed some IV medications like IV midas, IV loras. So IV midazolam, as well as IV diazepam, IV push 2.5 milligram. We told this can cause hypotension. Okay, adverse side effect, hypotension, and like bradycardia, the heart rate decreases. Sometimes respiratory arrest or cardiac arrest. So in a setup, when you're using these diazepam, midas and IV diazepams, we should be very much cautious, and we should be having a ventilator setup, intubation set before injecting high dose of diazepam like 20 milligram IV push, and there is 0.05 milligram per kg of midazolam. Then respiratory depression can occur even with oral administration. Tolerance to benzodiazepine can develop, and dependence may develop only after 2 to 4 weeks of therapy. Why? Because it requires time. The tolerance occurs only in a therapy of 2 to 4 weeks. That is why we are sleeping pills. We just told temazepam 50 milligram HS, flurazepam 50 milligram HS. These are if you are using for 2 to 4 weeks continuously or more than 1 month continuously, then tolerance will happen. Sometimes dependence will happen. We have to increase the dose. That is why. Okay. Next, a seizure and delirium may also occur in sudden discontinuation of benzodiazepine. Remember, seizure and delirium. When you suddenly discontinue, these benzodiazepines, we should be very cautious. There is withdrawal symptoms. Withdrawal syndrome consists of, there can be agitation. It can be irritability, then insomnia, tremor, palpitation, GI distress, like that. So perceptual disturbance begin 1 to 10 days after a rapid decrease in dosage or abrupt cessation. Short acting and intermediate acting drugs should be decreased 10 to 20% every 5 days. So for that, we decreases by every 5 days, to avoid this, um, to avoid this withdrawal syndrome. We every 5 days we taper drug by 10 to 20%. We taper by 10 to 20, especially short acting drugs as well as intermediate acting drugs. We taper by 10 to 20%. Okay, remember that. Next, why if you taper quickly, these actions are very high and onset is very high, very quick. If you taper quickly, it may cause withdrawal like insomnia, tremor, irritability, drowsiness. But these short and intermediate acting drugs should be withdrawn slowly every 5 days, 10 to 20%. But if it is a long acting, then don't worry. We can even stop much early. Okay, no problem with that. So overdose. The overdose, what does it happen? Overdose of benzodiazepine. We know benzodiazepine overdose. There's a drug called flumazenil. Flumazenil is a drug. We have heard about this drug in alcohol withdrawal syndrome also. Flumazenil. Flumazenil. This is a midazolam. This is a beta. This is a benzodiazepine. Bind to GABA receptors. The antagonist is flumazenil. Flumazenil competitively bind to this receptor and prevents its action. So the flumazenil action, it competitively bind on GABA A receptors. GABA A receptors prevent the binding of benzodiazepine. It should be at only 1 hour. So you have to repeat the dose every 1 hour. Okay, flumazenil. Next is trazodone. Another type of drugs for the treatment of anxiety and insomnia is trazodone. It's a serotonin antagonist. So also it's an antidepressant. That may be useful for treatment of severe anxiety and insomnia. So the dosage is 50 to 100 milligram at bedtime. It is highly sedating and can cause postural hypotension. It is rarely associated with priapism. Levels may be substantially increased when used with CYP3A4 inhibitors. Next, we should know there are some non-benzodiazepine non-benzodiazepine hypnotics. That is, we use zolpidem. We use zolpidem. It's a imidazopyridine hypnotic agent that is useful for the treatment of insomnia. It has no withdrawal symptom, rebound insomnia, or tolerance. So the uh, zolpidem action. The action is similarly, it acts on the GABA A receptors. GABA A receptors action and stimulate it, and the it stimulated like benzodiazepines and inhibit activity of neuron. It will sleep the nerve cells. That is, sleep. It will, what does it cause? It improve measures of sleep latency and sleep duration and reduces the number of awakening in patient with transient insomnia. So there is no, the good point with this drug is there is no withdrawal syndrome. There is no rebound insomnia if you suddenly drop stop this drug. Solpidem. It's a hypnotic agent also, and there is no tolerance also. No tolerance. Side effects include headache, daytime solemnness, GIT upsets. The starting dose we use is 5 milligram. Okay, 5 milligram at night. That is bedtime. Uh, the side effects is can be daytime solemnness. Daytime solemnness. Daytime somnolence. Okay. Next is saliplon. Saliplon. Another non-benzodiazepine. This hypnotic or drugs used in anxiety and insomnia. It is saliplon. Saliplon, it action is approximately 1 hour, and there is no active metabolite. The side effects include headache and dizziness. The starting dose is 1 milligram at 1 milligram at bedtime. Similarly, another drug is called azopiclone. Azopiclone. It's a longer half-life compared to previous agents. Side effects is similarly headache and dizziness. Starting dose is 1 milligram at bedtime. Okay. Another drug is a ramelton. Rameltion, REMEL, rameltion. Discussing of the rameltion is a melatonin. It's a melatonin analog. Melatonin analog. Since we know that drugs like steroids, beta blockers, um, and bronchodilators, it decreases the melatonin. So these drugs like ramelton use 8 milligram at night. Okay. Next comes the drug called antihistamines. Dealing about antihistamines, there are some sedative effect for antihistaminic drug. How these drug, how this causes the antihistamine causes sedation because the antihistamine action on H1 receptors. We know H1 receptors. They're located in the tubulomammillary nucleus of hypothalamus. Hypothalamus, there is a tubulomammillary nucleus. Yes, that result in drowsiness, sleepiness, and sedation. Okay. So the problem is the side effects. There is antihistamine can cause anticholinergic side effects, urinary retention, dry mouth, like that. So that's why we are not promoting this drug. So finally, thank you for listening to the class. Have a great day.